Thank you very much. Thank you very much for the introduction. And I thought that I used the privilege of being the co-moderator not to repeat some of the previous talk, to tell us what has been the progress, because some of the ideas are ideas that keeps coming back, right? These are some of my disclosures. I also have patents in this area, which is not a propriety of a company yet. One of the very few first paper on the subject is in the German literature, and I'm not speaking German, so it's difficult for me to read, but it's on continent colostomy using a magnet, vers something. and this device was used with a magnet in order to cause continence of a colostomy. And you can see there was a Caraya ring, and this was positioned between the skin and over the muscle, and this was an obturator, if you want. And they figured the Anziehungskraft, which is the attraction force, being the distance between the two being mostly between 10 to 30 millimeters. They've done patients, and then we've not heard any more of this. And I figured that a lot of these papers have been published, and then there was no follow-up of these concepts. And that, I think, because there were problems. And I think here probably necrosis occur over time, and infection or local infection, and then this was abandoned. Here's a non-suture microvascular anastomosis, and this is now we're going to 1978. So we have a 43-year history of those magnet used for anastomotic devices. This is an original method of non-suture microvascular. It took only 8.3 minutes to accomplish, to make a high rate patency in the anastomosis. And I think that this is working for vascular anastomosis, but I think one of the problems with vascular anastomosis is what happened with the ring after, if they cause embolization, and then you have another problem to deal with. And I think this is why it's not been, in use application. Is the clinical application for colorectal anastomosis. That's nothing new. We're going back to 1981 in SGNO, published by this group. And after 7 to 12 days, the magnets cut through and disappeared. They did 21 patients in 1978. There was 11 resection of the sigmoid colon, 9 low anterior resection. There was dehiscence of the suture line in 2 instances. One patient required an reoperation. And there's one patient who died on the 3rd post-op day. They say from MI, but I kind of suspect there was some problem with the anastomosis. And in the other 18 patients, there was primary intestinal healing. Now, there's a lot in the Russian literature. If you can get hold of those papers and you can read Russian, and I think I have a trip planned to Moscow in order to get those papers. But you can see Stepanov and Charipov have written a lot of this literature going back to 1982. Resection of large intestine using permanent magnets. Here's one used in children in 1984. And then the use of permanent magnet suture-free 1987. So you have a cluster of Russian papers at that time, and they were huge magnets and heavy magnets. They were not the magnets that we're using these days. Here's 25 dogs were used as a compressive intestinal anastomosis. Some were end-to-end and side-to-side anastomosis for large and small intestine. And they were coming out through at 4th or 5th day up to 9th to 10th day. I think 4th to 5th day is premature, in my opinion. And then they used the anastomosis after 25 dogs on 6 patients. And they used it to treat fistula in children using a bypass anastomosis. This is again Stepanov, going now to 1992. a new method using for exclusion of intestinal fistula, forming bypass anastomosis. The result now of 46 children in Russia in 1992 with the bypass compression anastomosis. Mortality rate among children was reduced from 31 to 13%. So perhaps. Now, of course, biliodigestive anastomosis, again, the Russian used it, used the magnets in 1993, and they use two variants establishing compression cholecystogastro-anastomosis. So gallbladder to stomach. In obstructive jaundice, they created in dogs, and eventually they did 16 patients with cholecystogastro-anastomosis, cholecystoduodenal, choledocoduodenal, and hepaticoduodenal. These were patients who were, with malignant obstruction and high operative risks. Then we have the same author came to United States and published in the American literature on this subject. And now we go to Cope. Cope has done in the vascular interventional radiology literature a few papers, one in 1995 on the compression gastroenterostomy using oral and percutaneous introduction or surgical introduction of magnets in swine. So using 9 pigs, they had 7 patent anastomosis, 1 partially patent at 7 to 13 days. And at 5 days, the anastomosis was not patent in the remaining animal. 1 anastomosis became occluded at 30 days, and there was no anastomotic leakage. So that was fairly good. And then they also studied the same thing on compression cholecystogastric and cholecystogenital anastomosis in swines. Now, all these anastomoses were fully patent in 4 cholecystogenostomy and then 1 in cholecystogastrostomy at mean 12 days. Partially patent in 1 and in the cholecystogastrostomy at 15 days and not patent in 2. So they played with different force, but they thought that 400 to 600 gram of pull, which is 4 to 5 times what your magnet is on the fridge, would be best in order to cut the tissue and have enough pull. Another paper by the same Cope in 2001 in gastrointestinal endoscopy, long-term patency of these anastomoses. This is again in dogs, and after a mean of 5.5 days, 12 millimeter diameter of their yo-yo stent was used, and gastrointestinal anastomosis with the stent was observed endoscopically and gastrophically at 1 and 2 months interval. So, do they stay open? That is the main thing. If we do an anastomosis and it's small and then it starts to close over time, then we have a problem, as opposed to what we do now by hand, by suture, or by stapling. And so at 6 months, it was mostly widely patent in most animals. There was a partial membrane in a 5th dog, and there was a minor breakage in 2 animals. So not completely patent on everybody. Benign obstruction in the common bile duct, the Japanese in 2001. And then there's this interesting side-to-side sutureless vascular anastomosis with magnet, published more recently in 2004. These are pretty small magnets that are used for vascular anastomosis. As you can see, they're oval in shape, 1 millimeter in thickness. And the interesting thing is that they are magnets inside, outside, outside, inside, so that you stick 2 vessels together after making an opening, and it is causing endothelial lining around these magnets, and I think it proposed a possible way of making anastomosis with vessels chronically. Then I'm just going to skip to that. Now we get to the compression, and these magnets are creating compression, and the compression concept is nothing new. We knew about the Murphy button from 1892, and it's just a continuity of those concepts. Then there was the 1984, the Valtrac, which is an absorbable material that when you put your two lumen together, this disintegrate and the anastomosis is formed. Doing this by laparoscopy was a big trouble, and we tried in 1990. Then there's NITI, and that is a circular Israeli prototypes and device that is used for circular anastomosis, mostly for colorectal. So we've designed the concept of using linear magnets by endoscopy above and below to cause an anastomosis between the proximal and GI tract. And after several days, there's a sloughing of the tissue and passage of the two linear magnets into the passage. So we have our early experiments going back 10 years ago. I've been looking at this concept in duodenocolic and duodeno-ileal anastomosis. And we studied those animals and harvested them and did necropsy and histology. And you can see that we achieve very good anastomosis and clear anastomosis, whether this is a duodeno-ileal anastomosis. This is the native duodenum, and this is going into the second part of the duodenum, and this is the ileum here. So this is a side-to-side anastomosis. Animals that did not have the sham operation were growing, plus 33% weight, while the patients who had this concept lost minus 6.8% of their weight compared to original, but there was a gap of more than 40% between the two groups. Also, duodenocolic, which is something that perhaps is too radical in humans. We had even more weight loss doing duodenocolic anastomosis. This is the control group growing versus the operated group. And in the duodenocolic, the difference was 54% of weight between the control and the duodenocolic, while in the duodenojejunal, the difference was 16%. So these are some of the specimens. You can see here that after 60 days, between the stomach, the duodenum in the animal, and the colon, there's absolutely no adhesions. This is a perfect anastomosis form, and if a histology, which I'm not going to show you, is absolutely perfect between the two walls. So we concluded that the concept worked perfectly at that time. And we started to do humans, and because of the nature of this meeting and the proprietary, I cannot tell you. I think that the concept is, what I can tell you is that the concept is working, but the problem we're facing is about safety of the anastomosis, because we have the way of doing anastomosis by hand, suture, and by stapling that is perfect right now, and the leakage rate is in the fraction digit of a %. Can we, with magnets, reproduce the same safety? And this is the problem we're facing, because we have different tissue thickness, different tissue between stomach, different thickness of stomach, different bowel anastomosis, different length of anastomosis, different age of patients, and different diseases process. And this needs to be studied in different circumstances. And I think that's why the human trials right now, from the 4 or 5 teams that I know in the world that are working on this, are ongoing. And we're going to need randomized series, which is going to be complicated, because we're going to have to do randomized studies comparing hand-sewn and magnetic and stapling and magnetic, and prove that the safety is the same and that there are added benefits to that. Thank you very much.